spent some time, what has liver to do with it in all this? Why it becomes slightly important in the whole case? And what do you do in the peritransplant? Because peritransplant period at this point in time, as it happens, may happen at different institutions. So it could be bias patient or things or US patient having a transplanted king, then they're going to be actually sitting home in the center. And then in the end, nothing is complete without outcome. You know, what are you all doing it for? So it's a good outcome or not? So Nigel said that in 1984 about liver kidney combined. I went further down and 10 joint transplantation became known. More than one organ was lost. And that was 1966. So when the first kidney and transplant were performed, what it did is it opened the field that you can do more than one. That's the idea. Nothing more than that. Technically, it's possible to do more than one. But if you look at the activity now, this is the UNOS data. UNOS is an American registry where they record all the organ transplantation that happens. And you will know all this data. But for completion, if you look at it, it's very small. And I think my figures come up a bit less than that. It's about 1.8% of the whole liver transplant and 1.4% of the whole kidney transplant, and that's clear. So combined kidney liver transplants were 4% of added in terms of, so majority is very rare. But that gives you an idea of how rare it is. Now, Nigel touched on indications, and I'm going to slightly differently present the similar information that Nigel presented, and I'm going to divide into three: disease leading to both the liver, liver and kidney failure, that we all know very easily, and stage renal disease secondary to liver-based metabolic conditions. Nigel eloquently presented the data for information both on methylmalonic acidemia and on glycosylceria. I'm going to be provocative there. Not that I 100% believe in it, but just to start some discussion. So just listen to that slide very carefully. And there are primary chronic liver disease, kidney as an innocent bystander. I call it innocent bystander because people like me who are responsible for the kidney failure. And you say, what kind of problem? So 1990, early when tacrolimus was coming in, and tacrolimus was active 506, and you're getting it, and the level used to go to Germany, Munich. It used to take 7 to 10 days, different days, or maybe 2 weeks sometimes, to get the level back. In between, we manage the patient as the creatinine going down. Then you imagine now, by the time creatinine went up, it's pretty late. Then the level comes, oh, can you reduce the dose? So, but you will be surprised, similar practice, not to that level, but it still exists, 10, 12, 15. And I'm guilty of another thing when I manage the standard transplant, our norm tacrolimus level was 25. If you got a report of 22, we'll increase it. So there is a lot to be learned and done, but history is very easy. Hindsight is 2020, so I'm guilty of that as well. But there is this practice continues. The reasons that 6.4% of kidney transplants performed are for calcium using that's quite high. And that's a failure in our part. You can't blame it on tacrolimus. That's the introduced use of this drug. Drug is very good, but we haven't really learned how to do it. And particularly in the era when there are so many other drugs around. So we need to take some ownership. So what is this fibrocystic polycystic disease? I will present ART-KD data. Just to give you an idea, this disease is a chronic illness. It's not just one organ. Predominantly what we see is a liver and a kidney. And we say, well, this is our area. But if you look at this poor rat, he suffered with this. And most of his organs, starting from thinking, God has been very unkind to this species. Look at every single organ is affected. So kidney, well, that's what belongs to us. But eyes, brain, ears, and then situs, the heart on the wrong side. She's a nice rat still. Skeleton, deformities, and liver. So if you look at this you recognize very well. This is how the kidney looks, but it's for the liver audience, you may not have seen this. So what's happening in the liver? So when you see a liver, you say, well, this looks like a lump of meat. It's easy to say, but his kidney looks much more attractive, nice, and kidney beans like organ, but this is a lump of meat. But if you look at the inside of it, this has a pattern. So embryologically it develops very complex. It is complex way. So there's a ductal plate. It's a happens is that when the portal tract is developing, the biliary develops around it, it has a pattern. And if that pattern is disturbed, that's when you start getting this pattern. So this got a yellow appearance where the branches are coming all over. Here the branches are coming in very organized. So when that happens, we get this. And it's not just one ADP area to PKD, you get this picture also, which is benign. More manual complex, we see sometimes normally in patients. So they have nothing else, but they have this, whether it's a minor variant of this or not. We do see it in our patient on incident trial. So it could be a whole gamut of things, Caroli syndrome, Caroli disease, autosomal recessive versus dominant, and ductal morphosis, involution, ectasia. So this side is ectasia, this side is involution. So these are the, we think that's our stuff. But that's our thinking, but we do know that this branching of the ductal plate malformation is secondary to how the involution of the ducts that at this level that may happen to the whole duct. Now this is a slide which tells us just the insight. But I don't want you to remember this, I don't remember myself. What I learned from this slide is that autosomal recessive polycystic disease does not tend to have a systemic figure. That's one learning point, and it is the most common of all what we see when in the liver. While autosomal dominant is a systemic problem, but they don't see much in children. In the dominant adult phenotype, but it's common in adults, but in children, ARPK is 1 in 20,000. After that, Sugar syndrome or others, they are in 100,000, 100,000, 250,000, fairly rare. So just to make the point, that 1 in 20,000 live birth, just a gene, and it has a hepatic fibrosis phenotype. If you go to the next slide now, end stage is this metabolic condition. So this is a picture of a random hyperoscuria, and we don't see this. This is just a complete from my slide. You all know it all, but this will be all as dreadful if you're not a renal person. I think you see more than us. But I divided it into these 4 or 5 categories in medical management. So medical management you all go for, what we do, hyperhydration, etc. that you guys you don't even get to know that. But certain things have changed since. And I'll come to your question over some others you know. People have attempted hepatocyte transplantation saying that this could do it. So on a piece of paper, on a biochemistry level, there was a definite change in oxidative suspicion on the enzyme product in that way. But it didn't really change outcome. So, but nonetheless, the proof of concept is that if you do have a normalization of the enzyme production in the liver, you could change the phenotype. Then we talk about preemptive transplantation, combined with sequential, later on we come to that again. But the future treatment is like gene editing. Now, this is a condition, single gene defect as Nigel portrayed, and for your patient I have 3 options. One option is my way, second is MGT way, which is rarely correct, and third is your way, which is patient choice. So in other words, I think what will come is to, at the end of the day, it's a patient. We can theoretically discuss whatever you want. And as Jill will agree with me, not many people die twice. You have to take a chance in the between one to move forward. Nigel showed this slide, and this is, I think it came the same color, so I'm sorry, actually it's the same color, Nigel. Maybe we shared it before. But the point here is that this patient's CFR didn't change much, 20. And you will say that's pretty good for a nephrologist. But we as a hepatologist start getting worried when we see 20. So he will say, well, that's pretty normal. That's for 4 years maintained. But I have a feeling that it won't stay like this forever. It will go down further, knowing the literature on hypercholesterolemia. And this is that came across only 3 days back. So I thought it was all a gimmick. But you have followed the news. So gene editing, so everything was going, gene therapy, there are clinical trials, we are doing some, some other diseases, and we thought that was the real thing to do, viral vector. But this is gene editing by this CRISPR-Cas technology. And it's extraordinary that this Chinese scientist has done it. And people are critical of him, he's reckless, he's unethical, and all that thing. Well, maybe they're saying because he did it rather than they did it. So I can understand why they're so upset about it. But what's the point doing with all these rats if they're not going to take in humans? But for people like me, young people know it all. But Nigel, for you and me, I think how does it work? So there is a cell, there is a chromosome there, there is a DNA, and what this clever technique does is there's a scissors, which was the cat scissors they call it, and it takes away that normal segment of the gene, and then join it up, and what you get is a normal product, which is all theory, all single, every single rat has been cured of it. But this is something that has come. So what I'm trying to say here is for conditions like hyperoxyuria, etc., single gene defect, these may be therapies on the horizon. So you could argue, but the time is limited because you can't wait for kidney to get damaged, then you have to do it. So the gamble has to be taken. If the therapy is very straightforward, never the case, but if it is minimum side effects, then even the phenotype may not matter. Because if your side effect profile, tolerance of the therapy is very good, then even if you overdo it, at least you take away all the chances of getting a kidney or a liver transplant. So coming to the other conditions, I spend a lot of time in pulmonary aciduria and atypical hemolytic uremic syndrome. And I think that these two indications, when I conclude, shouldn't be the indications in the modern world. So they should be taken care of by other ways of doing things, like particularly the immunological treatments that you got for this condition. So you shouldn't be considering kidney transplant for this condition or liver transplant. And kidney as innocent bystander, I already elaborated my thoughts on CNI usage and our failure to use it very, I would say, judiciously. Alpha-1 antitrypsin, cystic fibrosis, ciliopathies, I think there we make life difficult. Because you must have come across cystic fibrosis patients all their life, what they like is betamycin, amikacin, and all the same things that will happen. And but their focus is very different. The focus is to get rid of the virus and or the bacteria that they are there, but without realizing that yes, you can take on to the adulthood with the pride that our cystic fibrosis survival is 20, 30 years, but with the GFR of 30 or 20, that's not highlighted. So I think failure is on our part to have I think attention to detail is the phrase, and we don't use that in our own ology. So I don't pay much attention to kidneys when I'm doing liver part, because I'm only paid to look after that. Or my life is a lot easier if I start involving 10 MDTs, then it becomes more complicated. So there's a failure on our part, not, I think you have to admit it. Now let's come back to the liver. And so what is going on when your kidneys, your GFR of 30 is passing urine, and you say electrolytes are fine, nothing is too well. But you are the primary, for some reasons, you are the primary physician for that person because they came to you first. But what's happening on like chronic autosomal recessive polycystic kidney disease part is all these complications of fibrosis in the liver are emerging on the background, which is, Nigel said, portal hypertension, thrombocytopenia because of the hypersplenism, ascites, encephalopathy, and nutritional management, particularly in organic acidemias. Nigel made a comment, he doesn't like operating on these patients because they have been on plastic diet for their life. They are given that plastic food with the measured spoons of this, that, and other. Their wound healing is rubbish. Collagen is not delivered properly, so hence there is an issue there. But when you're aware of these things, you can do something about it. So if you look at the hepatic complications, this is data from a group that Nigel showed the data already. But if you look at 50%, up to 80% of patients by the age of 15 will have portal hypertension, but they all don't bleed. So this is where it becomes important how you proactively manage them. One simple will be just you go and do endoscopy and band them all, but then you're over-treating 40, 50% of them. But it's important to know that 10, 15% will develop cholangitis, 50, 40% will get a bleed, and then as the age goes by 15 years, 50% will have had a liver transplant. Now, you may not see this, but they come to us. I'm sure when in the shared care, they come to you as well. So big belly, umbilicus coming out with the veins predominating. But you have to imagine the hemodynamic consequences of this distension of down because of ascites and portal hypertension. Your kidney perfusion will suffer further if it's not already. And it will have implications on the hemodynamics because you're in a very vasodilated state. So your heart is working more than 100 times, 100% of its function.
So the consequences of portal hypertension could be listed like that. So you have increased pressure in the peritoneal cavities. That's one mechanism. You get extra fluid in the belly. That's the ascites. In the background of renal failure, that doesn't help because the fluid management is further precarious. Then you can get portal systemic shunting. The shunting will lead to few things that will develop abnormal veins. I will show some pictures of that. And then it also can cloud your consciousness called hepatic encephalopathy with either middle molecules or ammonia, which is one of the culprits for doing that. And splenomegaly will further reduce your blood counts, including anemia and thrombocytopenia. Now, these are historical pictures, but they are still in the medical school teaching are very good. Medusa head appearance, veins appearing in the anterior abdominal wall. If you see this picture, they are not uncommon, but when you have two organ dysfunction, both leading to increased intra-abdominal pressure, it's not uncommon to see these things. So just to rehearse, why does these things happen? And it's important to, when you know a bit of anatomy and physiology, it's a lot easier to communicate your treatment options to the family as well as your junior colleagues. So portal venous system is like this. It's a spleen. This is splenic vein. And then superior mesenteric and inferior mesenteric become and they make a hepatic portal vein. So simple physics, if you block this, you increase interruption to the flow by either by pressure or obstruction, the flow will go up here, or pressure will go back, spleen will get big, and your gut will get congested. But human nature is, human species is there to live. You find a way to get around. So what human body does is it finds a different way to shunt the blood around. And what it does is it makes different new veins. And that's what we call varices. So if the veins are in the near the umbilicus, that's what the picture I showed you, Medusa had. So these are the umbilical vein connections that are happening. They can happen in the retroperitoneum. They can happen in the rectum, called rectal varices that we call, and next to the stomach, and giving you this picture. Now, this is real. These pictures are not sketches. So this is the kind of spurt of bleeding that we see in portal hypertension in the stomach varices. And these are the ways to deal with it. So this is called as banding. So what you do is you put a rubber band on the varix, and that becomes like a bunch of grapes, and it slips off, and the vein thrombosis. As I said before, half the cirrhotics will have it, but only half of them will bleed. Not all of them. But mortality of the first bleed is about 20%, and risk of rebleeding is 50%. So when the patient bleeds first, then they shouldn't let go very easily. So when you identify varices in your patients, what do we tell them? We say, do not use non-steroidal anti-inflammatory drugs. So then they ask you, but I can use Brufen. Okay, so then you say, no, not Brufen. Awareness of GI bleeding. Tell them, don't go on a holidays which are cost away, It's exotic, but you can't find a venous access. So that's what you do, remind them. Take an transatlantic flight if the veins are not very prominent and the liver function is stable. Otherwise, you may bleed on the Atlantic and land up in a small island. And provide a written plan, God forbid they go to Mallorca, but give them a piece of paper and says, if this happens, this is what you should do. And that will help, and families will feel reassured. Prophylactic treatment is talked about. So what is primary prophylactic? Once we found the veins, what we do is we ask non-selective beta blockers, and we ask you, can we use beta blockers? And you say, what a need you. Yes, you can use it, but we like to ask you. So we don't know how it works. The question is, can you use endovasal banding? Yes, you can, prophylactically. There's a very grade 3+, and some places are using it. If you have a bleed already, that's secondary prophylaxis, then you do both. Then you do variceal banding and do non-selective beta blockers. When you get this acute bleed, then it's basic ABC, airway, breathing, circulation, octreotide, terlipressin. So what we do is we give them a piece of paper that says, this is the dose of octreotide or terlipressin, and make sure this hospital stops. So that if you need it, that's already there. Don't over-transfuse more than 9 grams, they will bleed again. Antibiotics are relevant, prophylactic, but they reduce the risk of the mortality in portal hypertension bleeding. Endoscopy within 24 hours. So you have time. You don't rush to endoscopy. Straightforward. TIPS procedure, I will show you what it is, and platelet transfusion if the bleed is platelet count. These are some of the still things we do very rarely, still do. It's can take acute, what it is you've read in the medical school that one is the gastric band and the stomach and the esophageal. Rarely you inflate this. Majority of the time when you inflate it, the bleeding gets increased. And this is what is called jugular intrahepatic portosystemic shunt. You can use it. Rarely, we have rarely used it, but it's quite a life-saving procedure. I think this is irrelevant. So we talk about each of the tip of the phone and a call, but we need to talk renal and liver dietitian. I gave one example. But there are similarly other allied health professionals that are involved in the care. They should be talking to each other. Fluid restriction versus, so we have ascites and we try to restrict fluid and you say, well, we need 2 liters to filter these kidneys, so we need to reach an agreement from there. Rifaximin is a very good drug that helps encephalopathic patients when you have cholangitis. So this is another story. You get this child has fever and we think could be cholangitis. But after 3 days, everything is good now. Can we stop antibiotics? If you believe it was cholangitis, then 3 days is not enough. If you don't believe it's cholangitis, then don't call it cholangitis. Treat it for 3 days, don't tell us, and we can stop. But if you tell us and say it's cholangitis, we will say, we'll insist it's 2. Very rarely obstructing strictures, very rarely. So we will not like to breach the endoscopically the biliary tree unless we are convinced that this is an obstructive stricture with ERC. In the chronic, now repeated antibiotics, we're very liberal, like Smarties, give them ciprofloxacin and norfloxacin. But I recently was educated that there's black box warning against Norflox and Ciproflox. Norflox is already taken off the market, and Ciproflox causing neurological problems. I'm sure some of our patients suffer to get into that or something else, but there is a risk, and this is the biggest risk. So multi-drug resistance, and this is on us, and it is going to be a problem. It's already a problem financially. The last epidemic hospital is just under £1 million kept under control. So it's no joke, honestly. Giving these antibiotics liberally fights back up. Decision making, timing of transplant, I think I have already discussed. Management of the waiting list, so take care of those things I have discussed. Pre-operative management, immediate post-operative management, and immunosuppression. Now this is a typical example of armchair protocols. Okay, somebody will show this protocol to me. You can list a child with this Crowley syndrome if the PELD score is more than 10. For those who know what PELD score is, it doesn't go off in this condition. So you can wait till this child to be dead, then the PELD score will be 11. So this tells you that don't look at this. If you either read it carefully or don't follow it. Combined versus sequential, I think Nigel has already done this job, but these are only, these are like just for classification and completion of the talk. Now this is an important slide, transplant and it's a kind of, getting the blessings of everybody, nobody claims that the things go wrong. That's all. Very cynical. But that is it, isn't it? Yeah. Oh, MDT agreed on it. Who is MDT? It's a faceless organization. Yeah, there is 20 people on the list. So what is important is identify comorbid anesthesia risk, cardiac risk. I think that's very important. Agree on the center where operation will happen. Once you agree, then it is a contract. I can't come to buy that you are seeing a patient as a travel but you need a contract, and that's a self-pay management. Renal replacement protocol, you will tell us what to do. Immunosuppression protocol, and I will make a statement. I think kidney is more important than liver. Liver is very tolerant, like hepatologists, surgeons. Liver people are very easy going. Kidney is, you need all those antibodies which are come from names can't pronounce. We just live with tacrolimus steroid. That's great for us. So we follow your advice, whatever you want. And I think transfer of care plans, that's important. So once you have decided that 2-3 days later the patient will go, then you will say somebody, so who's going to be contacted where? So have a clear plan. Helena is in GOS, call her. Okay. But you need somewhere, because otherwise they will say, oh, we can't transfer the patient, nobody knows who to talk. Or we go to switchboard and they are looking for the right person. Management of the waiting list, I think it becomes complicated. If the patient is on renal replacement therapy, they don't see us that often, and they shouldn't be seeing us. But I think a phone call or a communication to team is very important. As I said, immunosuppression used for kidney more than sufficient for liver. In the liver center, I think the length of intensive care determined by the pre-transplant status. Hence, it's important of the right time. And there is a data of the situation of the patient at the time of transplant that determines. So if you're very sick before transplant, then the outcome is not good. Daily discussion, it used to be daily discussion, now we have a review by the renal team. So Elena has been very proactive on this. So thank you for that. And transform PSH to renal unit for continuous renal care. I think that has to be coordination of it. I think I'm running out of time now, so maybe I will just say this is how we manage the intensive care, and this is the point I want to make. High incidence of pulmonary edema because fluid management, and there is always a tension between sides, sometimes too much, sometimes too little. There is a hyperdynamic state, cardiac compromise, but in hyperoxaluria patients, heart also, and the vessels, the compliance is very poor because the vessels are like pipes rather than a sensation. So we use ASCOM, I think, a device which helps us decision making. These are things which we don't do. So we don't use PCP prophylaxis. And you say, well, what is that, naivety or it's a cavalier behavior? I think we haven't had a problem with PCP so far. We had 2-3 episodes, but very late on by the time we stopped the prophylaxis. So we haven't seen the need. And giving another drug, it's not easier for us to sleep better while pumping drugs, but they have to take it. And if they don't take it, what is the other drug? Anticoagulation case by case, it depends on the movement of the sun that day, how they're aligned. The artery was small or not small. Nutrition usually I think I'm very respectful to kidney. The kidney allograft needs are higher than liver. Surgical complication, as Nigel alluded to, very small. Immunosuppression management predominantly by the renal. These are the slides Nigel is shown, but the colors are different here. What it shows is that outcomes. So this paper from Birmingham said that if you're under 15 kilograms, they didn't have any rejection. So that was the highlight of the paper. And after 15, there are some rejections. The outcome overall was good. So no renal graft age group, high risk of vascular complication. This is again a repetition of another study which I think Nigel has shown. But it just tells you that waiting time and donor to patient ratio were a problem. So mechanical ventilation at the time of transplant, how sick the patient was then, determines the outcome. This is a data, I think, just in a pictorial way, which is Marianne's nice pictures in the slide. And what it shows is this is a Birmingham data on 2 different phases, I think. So what it does is it shows that here, this is the Birmingham data and English data is quite old historical. If you look at our overall outcomes are comparable. Now Nigel said in the current days it should be 10% higher, but this is historic data. Now this is something I want to have a discussion in these guys out of that. I came across this paper from Boston Children, and what they suggested is to do bilateral nephrectomy at the time of transplantation for hyperoxaluria patients that reduces the risk of further oxidative position. They only had 4 patients, and they describe it, and they say, well, outcomes were not very different, well, it's number things, but it made sense, but if you tell me, it's a sensible thing. This slide is slightly different because this comes from a liver kidney transplant center. I think Hani Grewal was a fellow here. Yeah. So what it shows is that there are more indications. The cyclosporine toxicity, messenger proliferative glomerulonephritis in congenital hepatic fibrosis, and cyclosporine toxicity, etc. So there are different esoteric indications they had, but they show that liver kidney transplant, if you're a status 1, and status 1 in American system is if you're very sick or intensive care or high dependency, then the survival is also right. So that sends the point home that you need to think of these 2 arguments. So to conclude, ladies and gentlemen, I think there are 10 to 30 combined transplants are performed worldwide. And I don't know, I think the need may go down further if we are thinking preemptive liver transplant, and even if you are successful in gene therapy, single gene defect, then what you are left with is polycystic kidney disease, or even there you can do a preemptive kidney transplant or liver transplant while it's Organic acidemias and ARPD continues to be major indication. I think important recognizing and measuring complications, as I alluded to hypertension. And I think once I really want to use. Thank you very much.